Well, hello, everybody, and welcome back to the show. My very special guest today is Dr. Deepak Ravindran from the UK. Welcome, Deepak.
Hello, hi Wayne. Thank you for having me on the show today.
Excellent. So, Dr. Ravindran has 20 years of experience. He's a pain medicine doctor, and he works at the Royal Berkshire Hospital, one of the busiest general hospitals in the UK. Not only is he trained and doing pain, but he's also got certifications in other things called lifestyle medicine, which I'd love to talk about, and also musculoskeletal medicine. So he knows what he's doing, and he's definitely a forward-thinking doc who is heart and soul is in this job of his to help people not only treat pain, but heal pain. So it's really good to have you here today, and I'm honored as well to see you and meet you. So let's just dive in. Take us back a little bit. What led you into this world of pain within medicine?
Well, I trained in India. So it was a tertiary institute in India that I did my anesthesiology and my pain management and critical care degree of post-graduation back in 2001, 2002. And at that time, doing an extra qualification or a fellowship in pain. And that was one of my interests because within anesthesia, whenever I did regional blocks or regional techniques there, that was very satisfying for me. And I thought, well, if I wanted to know a little bit more about pain, and that's when I think the research around pain was starting to come out saying that, well, there are still these unknowns about what happens in nociception and transmission and all these things around chronic pain. So if I need to do a pain fellowship, I needed to come to the UK or at least go abroad. And that's when I came here to the United Kingdom in 2003. I wandered and went through the anesthetic training as it was required at that time. And I did my pain fellowships in UCL, in the University College of London and Royal National Orthopedic. And it was really interesting for me to find out that chronic pain, as we understood at that time, almost entirely consisted of, or at least the mainstream way that I was taught about, well, yes, drugs can help, and there's no such thing as addiction, and you can give medications. And then if you know, and if you have a good heart and a nice needle, you can get to any nerve plexus in any part of the body, and you can block it, and that should be all. And it was just around that time that Irene Tracy's work and functional MRI imaging was starting to get more and more prominent. And I think in the first 2-3 years itself of being a consultant in Reading, I realized that those two main tools that I had in my toolkit of medications and interventions weren't really helping for a lot of my chronic pain patients. And I had to really think outside of the box and work out what it is that goes into the pain experience. What else can filter and form part of what this person sitting in front of me in the clinic might be having. And that's what has led me down this path of musculoskeletal medicine, lifestyle medicine, just to understand what those other techniques and ways of managing the pain and healing the pain, as you said, are. That's taken me the better part of 8 years of my life now to where we are at this stage. So it's been a very interesting, very exciting journey with both clinical and bit of research hat on, but it's been fantastic to come through and be on this side now where I am.
So just tell me what you do in your day job. Like in a typical day, you're seeing patients, and how is it? Are you still doing interventional stuff, or are you just purely doing the other stuff? Like, what's the ratio of that?
So I started out, my consultant job was both anesthesia and pain medicine. So I had about a 60% of pain management and 40%. So 2 days of anesthesia and then 3 days of pain management. That was both. So I work in a district general hospital. So I do both inpatient pain. So, the acute pain ward rounds and post-operative ward rounds. And then, of course, the outpatient clinics, as it were, in secondary care setting. In 2016, I set up a primary care community service. I helped set it up as well. So I work there. So right now, my typical day is almost 80% is pain management, or typical week rather, and 1 day is anesthesia. And in a pain clinic, I still do about one session a fortnight is interventions. But otherwise, I do 1 day a week where I'm in the community working with physiotherapists and psychologists. I see patients who have been referred from the GP as the first port of call to the community pain service. And
Mm,
then at the secondary care hospital in the Royal Berkshire Hospital, I do about 3 days of secondary care complex pain where patients may have gone through the first layer in the community, but then either they because need an intervention or they have got other ongoing comorbidities or complexities or psychological or psychiatric issues. They're not suitable for community level management. I see them in my secondary care service where again, consultations with the physiotherapist, with psychologists,
mhm,
with my nursing specialist there. So we got an MDT team, and that kind of forms my typical work week now. Alongside it, I do about a research with the Reading University. I've got links with the psychological department there. They've got a cognitive neuroscience department. So I do a bit of project work looking into how do you manage waiting lists for pain management? What do you do when a person is waiting? How can you make their waiting time feel
mm,
less like a waiting? We're
mm,
looking at other projects around long COVID. So those are a bit an education around pain. How do you educate for pediatric pain, for adolescent pain, for just getting the message out, what it is that people want to know. So those all form extra bits there. And in between all of this, the last 2 years, I have taken the opportunity of one of my hospitals. They have a link up with the Henley Business School, and they're providing actually business management training for leaders, clinical leads. So I'm doing that partly because if we want to provide good quality pain care, want to provide healing environments to our patients, one of the big realizations for me is that the system has to change. Right now, the system as we work in
mm,
doesn't fully recognize the needs of our patients and how it needs to be ongoing in a way. And we need the whole system and the whole community to do the hymn sheet. So I am doing a little bit of advocacy and campaign work with a lot of community and health
mm,
care organizations in the community, but
mhm,
also working at a system level to actually say, how can you change funding pathways? What is exactly that rocks the boat of a financial director, and how do I get my clinical message in a
mhm,
language that they would understand so that the patient eventually can benefit from a system change?
mm. Wow, that's a big, a big endeavor. And so really important, obviously, we need to change the system for the benefit of the patients at the end of the day. So with all your experience, the purpose of this podcast, which is for the public listening in with chronic pain issues, what are some of the perils that you could share for them just today? Because you
Um,
know what they go through.
one most important thing, where I've written also a kind of book for the general public, exactly addressing that very question, Wayne. So thank you for asking that there. One of the things I want to get across to a lot of your listeners and viewers on there is that trying to think that pain, when you feel pain, that it is a signal of harm somewhere in the body, is a fundamental mindset change that you would have to make. And I think that's what I try to get across to my patients, is that our understanding of pain now is that it is a protection mechanism. So the question to think about it is, what is the pain signal, the experience trying to protect you from? It may very well be injury or an flare up of your rheumatoid arthritis or your osteoarthritis or some bodily change that produces chemicals, which is perceived by the brain as a form of danger, which can be relieved by medications or interventions, the appropriate kind of biologic drug you can make it. But I try to get across to the patients that I see in my clinic that that's just one part of it. That is just the chemicals that are being released by it. What are you doing about the remaining pain experience? How is it that the signal, when it reaches your brain and that the signal is being processed as a sign of pain, what else can you do to reduce that, to mitigate it? And I think if they understand it, that reduces a lot of the perils that you talk about, because when they don't get that connection, that's when they'll say, well, can I have another investigation? Can I have something else? Can I have another drug? And that is a risk, because if you go down an investigation route, it's going to show something that looks different or abnormal. And that means you go down a pathway of interventions or surgeries which may have never been required or is not being done in the holistic manner. Those are the perils I try to at least forewarn patients to actually say, think about the benefits of anything you want to do. What are the risks? Make sure you understand the risks, make sure you know the alternatives, and then you make a decision on there. So I think that's what I try to highlight in my clinical care and in everything that I do.
So what's the name of your book?
So the name of my book is The Pain-Free Mindset. So the mindset is actually an acronym there, wherein I kind of try to say, okay, no need to throw the baby out with the bathwater. You can still have your M, which is your medications. You can still have your I, which is your interventions, but understand about neuroscience, about stress, about trauma, about the connection between the mind and the body and adversity, how things in childhood or epigenetics can still make a change. The diet and the microbiome, which I've heard you talk about. Then, of course, sleep. S is for sleep, E is for exercise or physical movement, and T is for therapies of the mind and body. So it's a request for patients and the public and healthcare professionals to shift their mindset and then use the mindset to develop their own blueprint.
I like that. Congratulations on getting that little anagram. That's really clever. The pain-free mindset. So everybody check it out if you want some information. It's just to go into all these different areas that Deepak has been talking about. He's written this down in a very simple way, perfectly for you as the public with this problem. And because the reality is many patients, as you know, don't have a physician to spend the time and explain, and because they haven't had it explained, or they trained in medical school many years ago and it's not being taught at conferences and the traditional continuous medical education circles. So there's this gap still in 2020, and where
and I think that's what I like what you do, Wayne, because all these changes have happened in the last 15 to 20 years. These is not stuff that we read in our medical schools at all. This was not taught to us about the various changes around the microbiome, around the role of the fascia, the role of other connective tissues and other ways of looking at the human body and pain. And I think the way you do the videos and all that is really the important point to get the message across to members of the public that there are so many ways to think about pain and how to reframe it and actually how to heal it.
Yes, yeah, and I think it's not unrealistic now in this day and age with the science to talk about healing and to talk about curing, because I'm sure you've seen patients and I've seen patients who don't have pain anymore, and it's a fact. You mentioned briefly, I want to go back because this is a theme that's come up with me in the last month. And it's always a theme, but I don't know why this last month, but this concept of, oh, it's my osteoarthritis, doctor, it's my spinal stenosis, doctor, and this, even though they know what we're talking about, right? They're doing the work, the language that they use in the subconscious seeps out. And they say, well, my fibromyalgia this, or my arthritis that. And therefore inside their brain, the conscious conditioning just means, yeah, that's your problem and you can't get rid of it. And that needs to be unlocked. So what's a good way, what would you suggest for that solution?
It is a tricky one, Wayne. I've thought about it myself, and I think I'm still learning on the right way to frame it. My thoughts right now are that all of us need to have a mental model and a framework in which we want to view our life. And if many of our patients have got a label or a diagnosis which makes sense to them, which has almost not defined them, but at least helps them to navigate life circumstances, their jobs, their employment, the benefits that they might get from having a badge or any of those things, those are all very tangible benefits. To then when we ask them to make the change that no, this should not hold you back, you can actually go beyond it and become pain-free and become healed, in that sense. I think the biggest thing is, are they ready for then what is their framework? Do we give them an alternative to hang them? If they take away, or if we are asking them to drop their cloak of osteoarthritis or fibromyalgia, what do what is the new coat going to look like? Can they become completely normal? And that is often, I think, frightening for many people, because if you have been safe for a few years, for a few decades in one way of living, and you've got everything going right, do you want to change that into something where it becomes a little unknown? And I find that many patients do not want to move out of that, so that when they get a flare up of their pain, they've almost done exactly the right things. They've done all the things. They have these pain-free days, and they can say that when I do A, B, C, and D, doctor, I am fine. I don't feel much pain, and I can go and do all my activities in a day. But then this happened, and I think that's a flare up of my osteo. That's what's happened there. Or I think my rheumatology drug is not working, so I need to make an appointment to see the rheumatologist there. And I realize actually that that may be a tricky bit for me to completely change. I guess the way I'm trying to manage it now is in identifying that person and giving them the confidence to say, this condition need not define you. If you do these bits, the neuroplasticity element of changing and putting new techniques in can get you to becoming pain-free. Recognize that that is a label, but you can do a lot of things without it becoming a barrier for you. That change is very much dependent from person to person. I find a few patients are able to generate and maintain it. For many other people, it's often a relapse is likely. And I think life circumstances sometimes comes in the way. I'm yet to find a good enough answer, and our system, and that's where I come back to that, is our system doesn't have the capacity to support it. So I see them, I've given them the advice, they do a pain management program, they actually gain a lot from it, but we don't have the system to actually say you can have a drop-in session. When you have a flare-up, you can come back much quicker to take that support again. Certainly within the NHS, that's been a bit more trickier. We're trying to change that, but I think if we can get that part of the post-setup support right, I think we can maintain a lot of those patients to be pain-free and comfortable.
How are you getting on with working alongside your colleagues, like your physiotherapists, your occupational therapists, counselors? How are you getting on with integrating the neuroscience of healing pain from their level, their functional level, as their day job goes?
That's been actually, I'm blessed probably to have a team in the local area that have formed my thinking, but at the same time, I'd like to think that I've shaped their thinking as well. So it's almost like we're all working together from the same hymn sheet. It's taken time to achieve that. So I started as a consultant in 2010. By the time we got in a position to set up this service in the community, it was 2015. And at that time, we could appoint 3 psychologists and about 4 physiotherapists who would be doing the bulk of the service. I'm there just probably 1 day of the week in that service, providing some mentoring, providing some support, seeing a few patients in the community there. But the discussions with them, the first few years, and even now, we have some discussions. We have monthly topics where I talk about certain pain issues. I listen to some of their chats around the psychology aspects, the ACT and CBT concepts there, and physio and where there is. And I think physio in the UK now, they have this concept of what's called psychologically informed practice, because they've realized that if they can bring in some of those cognitive elements of thinking while they are giving the exercises, while making the suggestions, patients take them up much quicker. They can realize how to reframe some of the thoughts and the catastrophizing before they start an exercise routine, and they're able to bring it in place. So actually, it's been a collaborative effort. And often I tell the psychologists nowadays, look, have a discussion with them. But if they are stuck in a medical model and you need me to shake them, bring me in and I'll talk to them, and I'll almost tell those patients why trying to get your mind and the way you think about your pain also under control is equally important. So I don't try to derail the conversation by saying, yeah, it's all right, I'll do an injection for you. I am very mindful of how I converse with them so that I make sure their trust with and the rapport with the psychologist or physio is maintained if they are including me in. And likewise, my psychologists and physiotherapists, they'll tell the patient, okay, we'll help you with everything. Medications could be useful, and we'll send you for a medication advice with Dr. Ravindran, or in this particular case, the physio would have examined and said, I've done all these things, I've done the treatments, but there's one trigger point in the quadratus muscle that I think, Deepak, will be required for you to see, and you could consider maybe an intervention because I've tried a lot of these things. And I might say, okay, fine, I trust you, I'll see that there. I would then do an intervention in that circumstance, but I would say, I'll do the intervention, but nothing changes. You still have to do the work with my colleague because this is just enablement of your rehabilitation. This is not a cure in itself, but it can help you when you do all the other stuff.
Are physios being trained this at their school level now?
In terms of what? In terms of
the psychology side of their job.
So the Pain Physiotherapy Association in the UK they are now introducing these courses for psychologically informed practice. I think in the last 1 or 2 years, just before the pandemic, they've been talking about this. So it is a relatively new construct in terms of there. So I'm not sure, and I'm not aware whether physiotherapists in school are being taught this, but certainly in the UK, that's starting to become a movement wherein physiotherapists interested in pain especially are being informed a little bit more about the cognitive elements, how to frame their consultations and the language when they're trying to get them engaged in physical movement.
Yeah, good. Yeah. I think it needs to be across all the different modalities. Like, let's face it, right?
I think we need psychologically informed pain physicians as well.
Yeah. Yeah, well, that's a bigger subject. Well, that's why we do this, right? That's why you write a book. That's why we talk at conferences and we have podcast shows. And, you know, congratulations, get your podcast. So tell us about your podcast. Yeah, you've started this as well recently. So what's your one?
Oh, yeah, no, I've been watching you there. So I thought I should tentatively dip my toes in there. So the podcast is called the Pain Speak podcast. And my thought was, yes, it is. I want to be plain speaking about pain. So it is Pain Speak. And the first 6 episodes are already available on Apple as well as on Spotify. And they kind of framed an introduction to my book. So in my book, I interviewed a lot of patients and lived experience advocates in the UK has a sort of a door, an entry point to each chapter involved an interview with the patient. So those interviews were kind of brought together, edited for the first 3-4 episodes of the podcast. Right now, my present series of episodes is focusing on long COVID because I'm leading the long COVID service in the UK for one of the regions in my area in Berkshire. I thought it would be really useful. A lot of my GP colleagues, a lot of my other healthcare colleagues felt that they needed information. You know, there is huge amounts of information available already on the internet, but at least I felt and they felt that, okay, if it came from me and talking about what our service locally offers, then that would be useful. So I've been getting about 8 or 10 episodes ready for long COVID, the next series.
So, because some of our audience won't know what this is. So what is long COVID?
So long COVID is the presence of a number of symptoms affecting multiple organs that seems to be lasting more than 4 weeks after a typical acute viral COVID-19 episode. We expect that 90% of people would recover in 2 to 3 weeks after such an episode. But we've now found, and the latest data from the UK statistics body called the ONS has suggested that 1.1 million patients have long COVID in the UK, those whose symptoms are lasting for more than 5 weeks after the initial acute episode. And almost 2/3 of them, so more than 600,000 people, are probably having episodes lasting more than 12 weeks. I think in the UK, in the US and in Canada, the term that patients often use are called long haulers. In the UK, it's been long COVID is the patient generated term. The official UK government term is post-COVID syndrome.
Yes. And what are the symptoms?
So broadly, there are a huge number of symptom categories there, but I can give you the data from the first 150 patients that I've seen in my service in the last sort of 3 months there, and it's still 6 M's. Chronic fatigue is present in about 98% of patients. The next one is shortness of breath in about 80% of patients. Pain is there in about 65 to 70% of patients, widespread aches and muscle aches and joint pains. And then you've got brain fog, so cognitive dysfunction in about 50 to 60% of patients, new onset anxiety and depression in about 50 to 60% of patients, and then a series of things like GI upset, loss of taste and smell, tachycardia, palpitations, a lot of these POTS-like symptoms, orthostatic tachycardia there. So it's a wide variety that starts to affect multiple areas.
So basically the brain has been affected by this virus, and the lungs, obviously, because that's where it attacks, and then the whole body starts to
change in there.
Change.
I think the new data that's coming out seems to indicate that there was the study that was done in Oxford where they just took everybody through a massive MRI scan and looked at mild abnormalities that might be present in the organs. And they estimated that up to 70 to 80% of that group that went through, it's about 150 or 200 patients, if my memory serves me right, had what they would call mild impairments in function affecting many organs. So it seems that whether you're hospitalized or non-hospitalized when you had your COVID, you are prone to having really long-lasting sequelae with some functional impairments that could be responsible for some of these symptoms. And I think why it happens, it's still not fully clear. You're right about the fact that the immune system is probably the biggest player, and overactivation of the immune system affecting the brain could result in these parts there. But there's some suggestions that there might be some residual viral fragments in your GI tract that might be causing some reinfection or relapses in some people. They're suggesting that there might be some viral fragments which act like mirrors. You know, they imitate and they mimic some of the molecules that your natural body produces. So your immune system pretends thinks it's an autoimmune problem and starts to affect and attack its own. So that seems to be a rationale there. We are not clear actually even now why long COVID happens and what is the exact reason. I think research is ongoing, but it is really important that we recognize that this is a condition, a new long-term condition in its own right.
And I think one thing needs to be said, and it's almost impossible to research this, is looking at the media coverage of this problem and how it's all about masks, it's all about safe distancing, it's all about not traveling or staying home or lockdowns. And it's like, what is being said about nutrition? Like you've got in your anagram there, you know, N for nutrition. So what should we be eating to minimize this, right? What should we be thinking to minimize this? What should we be speaking about to minimize this? Exercise, you know, where is the message from the highest level on how to curtail the stress and the social pain of COVID or long haul COVID? Like, where is it? Like, really, where is it?
Now, that conversation just hasn't, you're absolutely right. That conversation hasn't started to hit mainstream. I'd like to think that, and I don't know, obviously right now, I don't know the conversation in the US and in Canada in how it's being done. So if you're saying that they're still talking about the initial acute part and are not focusing on the long-term aspects, I think that is a conversation that is very important to be had. In the UK, because we are on the sort of the downstream side of the second wave, and we're just starting to come out of the lockdown, the last 2-3 weeks, we've had huge number of webinars, new data that's coming out around long COVID, a little bit more clarification around case definition, the prevalence and the problems there. So we are getting this conversation in mainstream media of how to exactly tackle and what should be done about managing long COVID exactly in the domains of sleep and physical movement and other therapies there. Nutrition, there are some really good YouTube channels which are talking about this. And I think this is something that's right up our alley there. They're talking about anti-inflammatory diets, but they're taking it one step further. They're talking about low histamine diets. They're talking about histamine deficient foods to go for. And it's not something, again, that the NHS has got a good handle on, because none of us are really trained up in nutrition to advise these patients on how to go about doing it safely. So I think it's a unmet need, and we would need probably nutritionists or health coaches or interested people to do some research around this and understand it a bit more.
Yeah, I think that's the future, and it's really good to hear what is actually happening, because I know here in Canada we're heading into a third wave because of these COVID variants are taking over and the numbers are going up again. So there's a big fear across our country about this, and like, what the heck do you do? And I must commend the Brits, because they just jumped on board with this vaccine. And yes, there's ups and downs with vaccines and side effects and death related and situations and, you know, blood clots, etc., etc. But at the end of the day, smallpox and these diseases of old are not here anymore because of vaccines. Because we got rid of them. And yeah, it's going to be very interesting, because I know the world is looking at the UK as the guinea pig, as like, just vaccinate everybody. You know, I think you guys are down at the 40 age group now. I know my parents over there had their vaccines. So, but we're getting there too here in Canada. It's starting as a general rollout of age group, but you guys are way ahead. So I think you guys are going to be the first in the world to vaccinate the whole country. And then we'll have to wait and see. So I'm really thrilled to hear that, you know, the policymakers and stuff are researching in these up-to-date things. And, you know, it's just, we don't know the evidence, but we know a lot of basics, right? We know that inflammation is part of the pain world. We know inflammation is part of the disease model. We know inflammation is part of the post-COVID thing. And histamine is integrated with that. So right, it doesn't take too much, really. No. It doesn't take too much to do a little study, start showing it, start advising it, and we can all get better. Like, we can all heal from this. And that needs to be the message, you know, from the highest level. And that's what the funds need to be, you know, after the vaccination, I think. So yeah, so it's really good to hear, and I'm glad our audience is hearing this, because the world, wherever they're listening to, is having a different experience based on their culture and the choices of their governments. But we must move forward. Anyway, any last comments about anything you would like to talk about?
No, I think probably you asked me initially about lifestyle medicine there, didn't you? And I would have thought that this might be the right time to actually say that COVID and long COVID has made us really aware that these days mortality, yes, you can still have an infectious disease like COVID claiming lives. But before COVID came along, our biggest source of death was cardiovascular diseases and non-communicable diseases, which are increasingly, as you said, inflammation, stress-related inflammatory changes, neuroinflammatory changes that are driving it. And I think lifestyle changes, now without making it sound like it depends on the individual person, but I think lifestyle changes can be hugely beneficial, focusing on the things that we both are passionate about in terms of nutrition, in terms of sleep, in terms of the use of, you know, physical mind-body therapies and physical movement. I think all of that is what attracted me to kind of get that extra qualification in lifestyle medicine. I think there's an American College of Lifestyle Medicine, there's a British Society of Lifestyle Medicine, which is predominantly based in Scotland, by the way, and it's being led. They've been leading from the forefront and trying to get GPs and a lot of other healthcare professionals in the UK interested in bringing those 4-6 principles, because to get those principles, you need behavior change. And I think everybody's understanding that if you want to take patients and help them make the change, you need to create a system that's easy and convenient for them to make those changes and see the benefits, start low and start small. So I think lifestyle medicine gives that opportunity there. So I guess one of the last points I'd like to make is there is a lot of enlightened healthcare professionals in many parts of the world now, certainly in the UK, who are looking at seeing how we can provide a holistic integrated care to heal patients, not to just simply throw the next drug there, but has actually come up with a cohesive plan on how you can heal people. And I think that's the future we will be looking forward to in the next 10, 20 years once the pandemic's just a little bit in the background.
And I'm going to finish with Mahatma Gandhi little story, and you know well, coming from India, is a joke or a story where this woman came and asked him a question. He says, "Okay, come back in a week." So she came back in a week, and they gave the advice to the whatever it was about the child of the woman. And well, why did you not tell me last week? Well, last week I wasn't doing what I advised you. And I think one of the take-home messages, and it just, when you mention lifestyle medicine and lifestyle certification, it's like we're all patients. We're all in this together.
Yeah.
And as healthcare providers, we all need to be practicing lifestyle medicine ourselves. We need to be walking,
Absolutely.
we need to be eating low inflammatory foods, we need to be thinking certain things, we need to be seeing the bright side of different difficult situations and owning it. And then we can communicate that. It's not enough to get a certification. We need to be living it. And we all need to be. And I love the term physician heal thyself. I'll give you a little laugh. It was my last exam, my last question in my paper. I was in Edinburgh at the time in 2000. And it says this: physician heal thyself, Mark Twain. I thought, what? What does this question mean? I had 5 or 10 minutes left. I was out of time. And I think it was one of those added questions just to see what the doctors would say. But I thought, wow. And here we are, 20 years later. And it's the framework of my message is the physician is within us. We all need to take responsibility. And the healing is within us. It's in the DNA, it's encoded, it's there. It's a God-given gift to us. And we need to take responsibility and therefore change from the inside out. And when we do this, we can do it. We can all
exactly.
do it. We've been on this.
I think as Gandhi exactly said, be the change you want to be.
That's it. That's what he said. Be the change you want to be. So thank you so much. It's been wonderful to touch base. I look forward to meeting with you one day and get you back on the show, of course.
Absolutely. No, wonderful. Look forward to that, Wayne. So thank you so much for having me today.
Thank you. Bye-bye for now.
Bye-bye.